Hello, good evening, everyone. Well, thank you for joining us tonight for our webinar. This is Dr. John Santana, Dr. Thomas Nabity, Dr. Robert Farhat. We're at the Michigan Center for Regenerative Medicine. Thank you for joining us tonight. Our topic for tonight would be SI joint dysfunctions and treatments. So the SI joint is a pretty important structure in the spine. It's at the lowest part of your lower back where your pelvis meets the sacrum. It's a great mimicker of back pain. So a lot of confusion can happen when you have an SI joint pathology that mimics a lot of other components of back pain, from nerve impingement to arthritis and degeneration.
Exactly. So if you saw the Instagram, I did a brief talk about the sacroiliac joint, exactly what it is, what potential pain it can cause, what are the treatments, very briefly, but we're going to talk a little bit more specific about it. So I'm just going to do a quick anatomy review. So what we're looking at is the back of the spine here. These things on either side are the ilium, make up the pelvis, and in between the pelvis sits our tailbone, otherwise known as the sacrum. It makes a joint here that articulates on either side. Most people have two, and it's at the bottom of the spine. So we have to think about the spine, which we have a quick model here that I'll just pull in. So the spine sits on top, but sometimes this joint can mimic, just like Dr. Santana said, a pinched nerve or other pathology. So this joint doesn't move very much, but this bone is critical because when we walk, it sort of rocks back and forth and sometimes can have some dysfunction. In my experience, I find that, as I said before, it was a compensatory joint. So meaning that unless there's been some type of primary trauma, there really isn't a problem with this joint other than if somebody's had surgery, a fusion, but usually a slip and fall, car accident, or trauma usually will sort of put this joint out of alignment. Usually people will realize that they have acute pain. So our treatments that we have include traditional treatments such as physical therapy, manipulation, chiropractic treatment, corticosteroid injections, and then ultimately there can be more advanced procedures that can be done, but from a more conservative standpoint, injection therapy.
Yeah, the SI joint, unlike a shoulder joint or a ball and socket hip joints, really not supposed to move, and it's usually that movement, that laxity in the joint. So if you got the sacrum, the ilium, and there's movement going on, is usually where we see the pain patients with pain from that movement. And as Dr. Farhat had alluded to, oftentimes there's a trauma involved, where a slip and a fall or a car accident, where the pelvis is held in place, but the sacrum moves, and there's that trauma done to the ligaments. But oftentimes there's no history of trauma, and it affects both men and women, more oftentimes than women. And the primary reason for that is that joint does need to loosen during pregnancy, in particular as the baby's passing through the birth canal. And sometimes those ligaments don't tighten back up after that. My experience, it usually seems to be more common after a second or third birth than after the first child. But that's a common historical feature as well. Getting back to this being a very common mimicker of other causes of back pain, getting the right diagnosis is a critical first step. And our exam maneuvers we can do, along with the history, can oftentimes elicit that the SI joint is the target that we should be looking at. But unfortunately, there's no real good imaging treatments. Sometimes you'll see sclerosis or some sort of arthritic type of change in the joint. But most of the time, the x-rays, even MRIs, are completely normal. So that's where using a diagnostic injection can be extremely helpful. If we start with very conservative things like oral medications, topical medications, physical therapy, trying to strengthen the muscles and tendons around the joint. And if those things fail before we move on to more aggressive or invasive interventional procedures, it's good to really hammer home that you got the right diagnosis by doing a very targeted, very specific, accurate needle location to the SI joint using an x-ray machine, and then making sure that pain goes away at least for a day or two. That gives us that diagnostic response we're looking for.
Yeah, so the SI joints, like these guys said like it's not really meant to move so much. So when we do our provocative physical examination tests, we kind of try and stretch the joint a certain way. So the joint kind of has slight movements and variations. So one of the movements it can do is it has like a tilt. It can go forward or backwards here on the sacrum. So the ilium can go this way or this way. The other movement it can do is it can have like a shear movement where this kind of goes up or this side goes up. And it can also even fan out, like, for pregnancies and stuff like that. So when we do our physical examination in the office, we try and elicit those type of movements and see if it kind of mimics some of the pains that you have. So one of the indicators we have would be pain in the area of the lower back where the SI joints of the pelvis is, or even in the lower back. And sometimes that pain can even radiate to the groin, because if you look at the SI joint, it's not just one line here, it's actually this whole capsule underneath here is where the joint is. And so you can just imagine it kind of feels here, kind of stored to the joint as well. So after a good physical examination, a lot of times we can still get it wrong because, again, the body doesn't really read the textbook either. So, and that's where I think Dr. Nabity's good point about trying these diagnostic blocks to kind of see where it is, to kind of figure out really where the pain is coming from. So the injections that we do here are all image guided. So we try and guide the needle directly to where it needs to go, right inside this joint. So it's a very kind of tricky joint in that there's nerves and vessels and muscles and ligaments and tendons in there. So proper imaging, being able to kind of find that joint is a good idea. The other things to kind of watch out for too is because the spine is directly right on top of it. There are also the facet joints at the L5S1, which is kind of just a little bit above it, can also mimic some of the same pains in this general area as well. So that's another area that can be confused, and doing these diagnostic blocks would be a good idea to differentiate the two.
So statistically speaking, according to the data, about 20% of pain in the back is related to the sacroiliac joint. And the stats are based on somebody that hasn't had surgery. Now, it's usually unilateral, so it's usually on one side. It typically doesn't refer pain below the buttock, but can. And typically doesn't refer pain above the waistline, but again, can. There's also two innervations of the joint. So there's a posterior innervation, so there's an innervation in the back. There's also an innervation of the front part of the joint too. So that's what Dr. Santa Ana is talking about. So sometimes people can have referral pain into the groin versus just unilateral down into the buttock. Usually hurts more when you're sitting than anything else. Again, these are most common stated reports, but everybody has a little bit of different presentation. One of the other things that you don't really see on this model is that there is a tremendous amount of ligamentous structures here that hold this joint in place, and that's what keeps it from moving very little. But there are several ligaments that fill in this little gap, as well as from the bone up into the part of the pelvis there's a huge amount of muscle that keeps this in place. So there's a lot of things that can keep this joint supported that you don't see on this model. So it can mimic a lot of different symptoms, so it's difficult sometimes to determine. Now, this 20% I mentioned is usually folks that haven't had surgery. In my experience, people that have had lumbar surgery, specifically a fusion, that stat is way higher. It's dramatically higher, probably like half the time. If L5S1 is fused, they still have back pain. It's probably the sacroiliac joint. So there's several different provocative maneuvers in the physical exam. There's been statistics that have shown if you have at least 3 of those provocative maneuvers, then the chances of sacroiliac joint pain are significantly higher versus, say, 1 out of the 5 or 6 different modes of testing it. But by far the most sensitive and specific is doing an injection into the joint to confirm or disprove that this is the cause of your symptoms. So
the difficulty in diagnosing this, I've personally experienced as a patient. I diagnosed myself at an acute onset of back pain. Did nothing more than grab a cup of coffee and twist it. The next thing I know, I couldn't move my left leg. Like, just every step hurt. No numbness, just it hurt. It wouldn't work. So examined myself, thought for sure it was a facet joint. My partner was gracious enough to give me a cortisone shot in my facet joints, very close to where the SI joint is. So It makes sense why that pain pattern oftentimes overlaps, the facet joints being where the two spinous processes hit. I don't know if you want to kind of point that out, but I had Dr. Santana here give me some cortisone, and yeah, I thought maybe it felt a little bit better, and kind of tried to get through my morning, and by afternoon it definitely wasn't better. So I asked him to give me an SI block, and literally jumped off the table. Pain was gone. It's been about 6 weeks. Pain's still gone. Working on my exercises. The idea is that the cortisone isn't fixing the problem. It's not stabilizing the joint. It's the exercises that are stabilizing the joint. The cortisone is going to wear off certainly in the next couple of weeks. I'm hoping the pain doesn't come back, but if it does, I think it really feeds into what would be the next thing. If I'm doing the right exercises and that pain keeps coming back, I don't want to have cortisone thrown in that SI joint over and over and over again. Pain's a privilege. Pain's your body's way of saying something's wrong, fix it. And if that wrong problem is there's laxity in that joint, next thing I'll ask for is a regenerative procedure. Mm-hmm. And we have a handful of them that we can offer. And I'll let my surgeon, my physician discuss those, because this is the guy that shoots me up when I need a back stem cell or various PRPs that I've done my shoulder a couple of weeks ago. These are the guys that help me out.
Yeah. So that's an interesting case that Dr. Nabity mentioned, because like it is like the presentation of the pain is right here in this general area, right? So it's really easy to guess it's got to be coming from the spine. So this is that facet joint we were talking about, like right in here. So it's super close to where the SI joint is. So it's why it's easy to confuse it with the other one. And just kind of moving the needle a little bit to a different structure, just a little bit lateral to where the SI joint is, made the big difference altogether.
9-day difference.
So yeah, and he's absolutely right. The cortisone injection is one of these injections that we would do because it's one of those things that's needed to be done to get you through this episode, right? It's not a treatment plan. It's a way to kind of address the symptoms, whether to address the symptoms so you can go on vacation, or address the symptoms so you can go to physical therapy and actually address the mechanics that's causing the issue, or just enough to kind of, kind of get through your day. But for a long-term treatment, as an orthobiologic option that we can do, there's options with PRP and even the bone marrow stem cells and the lipoaspirate or micronized fat stem cells. And the idea with that is kind of similar to how we've been kind of looking at structures in your spine. Everything is based on having stability in this general area. So even though the SI joint is a joint, it's a joint that's not really meant to move so much. And that's why it's locked in by all these ligaments and tendons. For whatever reason, wear and tear, injuries, trauma, you get all this excessive movement that's happening in this SI joint, and the body doesn't like that. So putting the biologics in there on the ligaments, that's strengthening the stability of the joint into the joint itself, can actually help regain that stability, that strength of this area. So when you do those movements that causes a lot of movement in the SI joint, a lot of strain in this area, it's not going to cause any more pain.
And unfortunately, fortunately, it works 85% of the time statistically in our practice. But for those that it doesn't work, if movement's still the issue, there are surgical options. Stopping movement with either a dowel that goes into the joint space that then grows and fuses that joint, or taking a pin and 2 screws and putting it across the joint is a surgical potential treatment for this.
Well, those are obviously the last resort options when all else fails. We've confirmed the diagnosis. Patients are still miserable and not functioning, right? But there is a fix. Now, how many times, if you fuse one side, you have to fuse the other side, right? That's the only downside, I think, is because if we artificially stop moving this joint, well, potentially this side could move more. So that's the only, I would say, negative to that. But hey, we're trying to restore people's function, right? So we have to verify what the issue is, treat it appropriately, do the best with what's best for the patient. So.
Yeah, fortunately, these conditions are very, very amenable to treatment if they're not resolved with cortisone PT. Both the biologics and the surgical options have very, very high success rates.
Yeah, and then what we'll do is we'll tailor the treatment based on kind of what your requirements are, what your goals are, whether it's, extend pain-free to be able to be very more active, or is it a matter of just kind of reducing the pain so you can do just activities at home? The nice thing about what our practice does is we have all these options we can give you. We can give you the conservative management option, we just kind of watch and wait and monitor with physical therapy and chiropractic adjustments or manipulations to OMT. Or we can take it up a step, another notch up, and we can do these blocks, these injections, these steroid injections. It could be one of these treatments that you get, 2 or 3 times a year, and then you're good with that. And then next up would be trying the biologics and see if that's going to help improve your symptoms, which a lot of times it could. Or if that's not what you want to do and you want to go straight to have the SI joint fusion, that's available as well. And all these are minimally invasive. They're all done in the same day. You go home the same day, and the recovery is pretty quick.
We do really try to pride ourselves in talking to people about all their options, from the least invasive to the most, and incorporating as many of those that we can safely offer within the same footprint. And I think the SI joint is a great example where really we have everything from soup to nuts as far as what a patient might need in order to get a good outcome.
I've got a question for you guys. So let's say a patient comes in, this kind of actually happened to me, is a patient comes in having some axial back pain, right? So we tried doing some facet joint injections, helped for maybe like a couple of weeks. And then, okay, let's try your SI joints. Do the SI joints, again, same thing, like less than a month of relief. What would you guys think like would be the next step for that? Because I mean, I'm sure you've kind of encountered some of those things too, right? Like these kind of difficult kind of things to find.
Yeah, to me it sounded, especially if that history is, it helped with pain A, but the facet injection, but it didn't help with pain B. And then you do the SI injection. Oh, that helped with pain B, but it didn't help with pain A. And a lot of times, most of us, after a certain number of birthdays, have more than one problem.
Yeah.
We have a couple of
Yeah. Yeah.
And I heard an analogy once and really kind of resonated with me. If you got 2 fingers in hot water and you're able to pull one of them out, but the other one's still in there, do you still have pain? It's like, yeah, we got to get both of those issues out.
Oh, I like that.
So that might be a case where most of the time as a pain doctor, you want to do the minimal number of injections that you need to. Now that you've done shot A, facet joints, shot B, SI joints, that might be a patient who I would say, hey, let me do them both on the same day.
Yeah.
Let's see if I can get 100% of your pain gone. And then we can diagnostically know, okay, both issues are problems. Let's talk about what the next steps might be. For the facet joint, if we're talking about insurance covered procedures, or radiofrequency ablation might be what I'm talking about. If we're talking about biologics, boy, we'll treat them both at the same time. We can do PRP to facet joints, we can do PRP to SI joints, we can do bone marrow concentrate lipoaspirate to those conditions, but knowing that both need to be treated is a much better time to do before the biologic than at your 3-month follow-up where, yeah, my pain A is way better, but now, doc, there's another area. We got to draw your blood again. We got great PRP again. Hitting them both at the same time. So using those diagnostic injections on the front end of treatment to make sure you got the treatment probably how I'd handle it.
Yeah, nice.
Smart. I like that.
Yeah, I like that approach.
Because that happens a lot.
Yeah, it's
or the ball and socket is another
right. Like this is another kind of
greater trochanter,
right.
Like those other compensating areas, the kinetic chain, knee bones connect to the hip bones connect to the spine. So if you got a problem in one weak link in your chain and it's been there for more than a couple months, there's a chance you can start getting some collateral damage in other areas.
Yeah. So yeah, I mean those are all really great approaches. Like so there's one patient that I had actually. We ended up getting an MRI of the lumbar spine, and he had an angular tear at L5S1, and so that's where it's coming from.
Yeah.
So yeah, kind of interesting how it all kind of mimics this pain in each other.
Yeah, I mean the difference in distance between L5S1 facet joint and SI joint is maybe like 2 inches, right?
Yeah.
So like
For some of us.
pain, right? So like. Yeah, it's like take your pick, right? Like, okay, try this, try that. That's why it's sometimes challenging to differentiate. So I feel your pain.
Yeah, literally. I can say that. Well, I hope you guys found this informational. It's definitely something we see a lot of. SI joints, I think, are becoming more and more recognized as Dr. Farhat alluded to, as a legitimate pain generator of the back. And it's one of those sciatica causes that we're very good at diagnosing and treating.
Any questions?
Yeah, we don't have any real questions that have come up. If anybody's got any, if you want to type them in real quick, but otherwise, I think this is a wrap.
Yeah. So if you guys have any questions or you have any issues that you want us to go over, you can always reach out to us. You can email us at support@mcfrm.com. Better yet, you can call our number. It's 248-216-1008. You can set up an appointment to speak to any one of us and our team. I'd be more than happy to kind of look at what's going on and hopefully give you options as far as how to address these issues.
So we had one question come in. We got time. I think we
Yeah,
have time for a question that came in. So, can you describe what is PRP? How does it work? Does it work if you had spinal fusion?
Yes.
Rob?
So what is PRP? PRP stands for platelet-rich plasma. So that's where we take your blood, a sample of your blood, we concentrate it down. What we're trying to get is growth factors that are in your blood, primarily platelets and white blood cells, that we have a manual process in the lab that we separate those, and we get this sample, and it's a concentrated portion of those. We measure those. So instead of saying getting a cortisone shot here, we utilized your own body's blood product, the platelet-rich plasma, and that's what we're injecting. As far as having a spinal fusion, absolutely, right? You still have veins, you still have blood that's flowing, so that's not a concern as far as having previous surgery. So that's the inject date that we use. Now, if there are questions, we have a ton of stuff on our website that you can look at and review. We talk about PRP, we talk about the stem cell, bone marrow injections. We have a little lipoaspirate discussion, but those are the things we do here. When Dr. Santa Ana has mentioned biologics, orthobiologics, those are the things we're utilizing, your own body's healing mechanisms in order to heal you from within. So that's what PRP stands for, platelet-rich plasma.
Got a couple questions coming in, so we'll take them as they come. I have right hip arthritis and was told I have SI pain due to my hip.
Yeah, I mean, if you kind of look at this model right here, they're all kind of within the same neighborhood, right? So your SI joint is over here, your hip joint is over here. So potentially, they can all affect each other because everything kind of functions as a unit. So when your hip joint moves, part of this also moves. They're all stabilized. This area, your gluteus muscles are back here, attaches to this part of your hip. So they're all kind of generally related to each other. So one of the things that's nice about orthobiologics and regenerative medicine is that different from how traditional medicine is. In traditional medicine, we usually just find one thing and treat that one thing, and we focus on that one thing. But the body doesn't work that way. It's not isolated modular things. Everything's kind of interconnected. So when we plan for these orthobiologic injections with PRP and stem cells, we look at the entire functional unit and try and see how they're all related, how they all function together, and how it causes your pain. So you're absolutely right. If you have like a hip pathology, you could potentially have like SI joint issues too, only because it's compensating for what's going on in your hip. So it's worthwhile looking at those areas and seeing, is it the SI joint that's the main issue that's causing the hip problem, or is it the hip problem causing the SI joint problem? And hopefully treating both would give you the relief that you need.
And that's what I was saying earlier. In my experience, it's a compensatory joint, right? So it essentially takes up the slack from some other pathology, and that's where people will feel it. So that's why it's kind of critical to sort of peel away the onion to verify where the source of the symptoms are coming from.
How about both hip pain on the outside? Would that be SI joint?
Typically not. Usually, again, this is my experience, people refer to that as trochanteric bursitis. And again, in my experiences, I find it is a compensatory pattern. Again, there's some other pathology that's causing you to walk abnormally or change how you normally walk. So then there's a fluid-filled sac that helps lubricate the tendons over the hip, outside the hip, and that's the trochanteric bursa, and then that gets inflamed, and people will feel that. People have trouble laying on their side or touching it is painful. But again, could it be sacroiliac joint pain? Maybe. but you feel it out here on the side of the hips. That's why it's critical to make sure we evaluate and examine you appropriately to verify where is the pain coming from. Even though you feel it one place, that might be the necessary source of the pain.
And that's another indication where a diagnostic block oftentimes is real helpful. Put a little lidocaine cortisone there, your pain goes away. Yep, it's trochanteric bursitis, not SI joint pain.
Yeah.
Can SI pain radiate to upper hamstring? I have a problem there after driving for an hour or so.
Well, yes and no, right? It's again one of those things that yes, it can kind of maybe mimic some of that pain, but it'll be interesting to see too whether it's an issue here in your ischial tuberosity, where you have ischial bursitis. A lot of people call this your sits bone. So your hamstrings all attached to this bone right here. And again, the proximity to where the SI joint is really, really close. It's close to your hip as well. So being able to diagnose these properly will help us kind of develop a treatment plan. But yeah, so it's probably here in your ischial bursa that's the problem, where the hamstring tendon is attached to, or maybe even like a pinched nerve in your lower back, because that all kind of travels that same pattern as well. So again, careful examination and finding the right diagnosis is important to figure out a good treatment plan.
Similar question, can SI pain go all the way down to the calf?
So there has been some documentation because of this innervation that happens both front and back of the joint. There can be a similar referral pattern to sometimes a pinched nerve. And typically it'll follow an S1 nerve pattern, which will go down the back of the leg, calf, sometimes all the way to the heel. But you have to, again, we keep harping on the same point, which is really critical, which is why we all keep mentioning it. We have to confirm what the diagnosis is, because there are many mimickers of this problem. So could it be a pinched nerve? Could it be SI joint? Yes. It could be hamstring referral, lots of different potential patterns, but yes, it could be SI joint pain.
I misdiagnosed it in my own body. It's hard to diagnose.
Yeah.
And those diagnostic blocks are really, really helpful and we don't quit. Like, we didn't get it the first time, doesn't mean we're going to find it. Like, we'll find the pain source, and then once we know the pain source, we can really hone in on that treatment plan.
Yeah.
I appreciate everybody that showed up tonight. We don't want to belabor the topic too much, but if there's questions we didn't get to, if you have further questions, please support@mcrfrm.com. Give us an email or call 248-216-1008. The website is regenerativemedicinemichigan.com.
Thank you.
Thank
Good
you.
night.
Have a good
Thanks,
evening.
everyone.